do. Which one? Okay. Oh, okay. Thank you. Okay. No, you need to give me the number. Mm-hmm. Mm. Mm. I need to. Mm-hmm. Yes, I need to. That's my pen on me. Mm-hmm. Is it supposed to be? Okay. Mm-hmm. Okay. Can you hear me? Can you hear me? Okay. Mm-hmm. Mm.
Thank you so much for being part of the broadcast. The timer started up until the time. It's good night from us. But before that, I want to remind you there's a whole lot of reporting going on different media platforms. For now, here on NBS, let's now link to Mildred Tahaise, who is live from the NCC. Mildred, what do you have for us tonight? Bright colors in your background. You look very splendid today. Thank you very much, Isabella. Thank you very much, Canary. Definitely, Canary, you can't be asking after the announcement yesterday that got the minister dancing. I haven't seen her dance that much in a very long time. But after the World Health Organization declared Uganda Ebola free, of course, it was cause for jubilation. I do remember, I think it was early 2008 or thereabout, the pictures that will be on the background. That is how my mom looked. And as a young girl, I just couldn't comprehend, but there was this very terrible disease and living in a hospital quarters. I didn't comprehend it that much, but I realized every time she would come back home, and everything has to be disinfected, and she tells you, please step aside, don't come close. It set a totally different tone. Now, when we had a declaration once again on 20th of September last year, I could recall the trauma that we went through as children, and that is why I was very passionate about, communicating that this was not like COVID-19 as well. It was not like any other disease. It was in its own category, and of course, the minister will be declaring that. Fast forward, of course, unfortunately, we had hundreds of, infected people. We had some contacts, but the Ministry of Health worked tirelessly
out of the 9 districts that reported a bit of cases, of course, Kasanda Mubende, where it started from, and then we went on to Kampala. We had some people escaping, quote unquote, of course, escaping medical attention, but that was very, very unwise because they ended up exposing so many other people. But the good news is that from the 27th of November last year, up to yesterday when the declaration was made, there was no new case at all. And that is how we were declared Ebola free. But what does this mean? What do we do next? Does this mean forever there will be no Ebola? Those are questions that many Ugandans have been asking. But also during the Ebola season, there's so many people who said some gatherings were accepted, others were not accepted. Where is the science? Of course, we have the scientists here. They will be letting us in. Now, for you who wants to join this on our social media platforms, the hashtag is Ebola Exits UG and also UG Ebola Free. Those are the 2 hashtags that you will be able to use. In case you have any question, please go to our social media handles at NBS TV on Twitter, NBS Television on Facebook, Next Media Services. But also, you can send in some of those questions coming through on the Afro mobile app. You know this as a Frontline Thursday, but it's a totally different discussion because health is as important. They say a healthy nation is a wealthy nation. It is not my time. Let me hand over to the very able Charles Bonguhia, who will be taking us through this discussion, and I'll be searching through all your questions to make sure that these will be answered. Charles, over to you.
Thank you very much, Mildred, and thank you very much, the news team, for bringing us to this hour. This is a very special edition of the NBS Frontline. It is in form of a town hall, and like Canary said, we're in the NCC. Many people don't know what the NCC means, but they don't need to know now. It's not important. I will be discussing Ebola, epidemics, outbreaks, how they are fought, what it means to be declared Ebola-free, and one very important question Mildred asked. When you're declared Ebola-free, have you actually exited? But if you find a case tomorrow, what happens? We've seen some of these cases happen in the Democratic Republic of Congo. You get very close and then you're still very far away. We have people here who were involved in the fight in Liberia, Sierra Leone, and other places. And of course, Uganda's very rich history, unfortunately, with dealing with epidemics. We have learned a lot. I have reshuffled the frontline panel significantly. Quite a number of ladies. So the Honorable Winnie Kiza is in good company this evening. So let me introduce the Honorable Winnie Kiza. Is a frontliner, former leader of opposition, former member of parliament for Kasese, representing Kasese district, and from the Alliance for National Transformation ANC. Very nice to have you, Honorable Winnie Kiza.
Thank you, Charles. Good evening, viewers, and good evening, fellow panelists. At least for once, I'm comfortable amidst sisters.
You're in good company.
Yes. Very good company.
I have. Let me interrupt your celebration and introduce a man just next to you, Professor Bruce Kirenga, principal investigator, Ebola vaccine trial. Very nice to have you, Professor.
Thank you. Good evening.
Thank you. I have Dr. Nanyunja Miriam from the World Health Organization. Very nice to have you, Doctor.
Thank you. Good evening.
I have, from the ministry, the lady you said was dancing for the first time in a long time. Dr. Jane Ruth Acheng, Minister for Health. Very nice to have you.
Good evening, viewers, and thank you very much for having me here today.
Always a pleasure to have you. I remember many years ago we had a very intense debate, and we're discussing another outbreak, which was the nodding disease syndrome. That's many years ago.
I think the last one was COVID-19.
Before COVID-19, the one that sticks out really, because COVID-19 I think was with us for quite a bit of time, but the discussion about the nodding disease syndrome, you hadn't become a minister then, yes. And I remember you asked me a very, very interesting question. You said, Charles, have you interacted with a nodding disease patient or victim? Do you understand what it means? You're asking questions in the studio. I still remember that. It's more than 10 years ago. And let me introduce, from Kasanda District, Miss Phoebe Namlindwa, who is the RDC for Kasanda. Very nice to have you.
Good evening, viewers, and thank you so much for hosting us.
Thank you. I want to start with you, the Minister, and ask a very straight question to you. We saw the celebration yesterday. You'd been updating us on the countdown. And I think you must have been on your knees praying and saying that nothing should go wrong to distract from the countdown. Ebola is over officially by yourselves and the World Health Organization. It's over. You call this a de-escalation period. What is a de-escalation period? To a very ordinary viewer in her district in Kasanda, what does this mean? De-escalation. And if you could also add for me, for a country like Uganda, been suffering quite a number of outbreaks. This is the 5th Ebola outbreak? Seventh Ebola outbreak, different intensity, neighboring a country that has had a huge epidemic, which was the Democratic Republic of Congo, experiences from Liberia and elsewhere. What happens during this period of de-escalation? Start from there.
Thank you very much, Charles. First of all, allow me to correct you a little bit.
Sure.
When you say Ebola is over, I think it is much more proper to say this outbreak is over. And I say that because Ebola is endemic within this region, and outbreaks will continue to occur.
Could you break down the language for us? Endemic means what?
I will come to that, but allow me first of all to congratulate Ugandans upon overcoming this outbreak. And yes, I danced because I was happy. I wish many other people had joined me. It was also part of releasing, the tension and the pressure. So back to the issue of Ebola. If you go deeply in history, the Ebola outbreaks tend to occur actually more within the East African region, because even South Sudan is in the East African region. And one outbreak occurring after the other, when we still don't know the source, when we still don't have treatments in place, means it will occur again. Until we know exactly the source and how to prevent it completely. So when an outbreak is over, we say this outbreak is over. And then we continue with preparation and strengthening the system. Now, when you talk about what de-escalation means, first of all, we are not going to carry out activities as were intense activities as we were carrying out during the outbreak. However, it does not mean we are going to stop carrying out surveillance. Surveillance is a routine intervention that we carry out even in between outbreaks. Because we need to continue combing these districts to ensure that there is no silent outbreak going on. And in this particular phase where we have had this Ebola outbreak, we want to be very careful and ensure that it doesn't surprise us anywhere. Just like you mentioned earlier on, that there would be other surprises with our neighbors. Day 41, you get a surprise. We don't want to get that surprise. So for the next 90 days, we are going to continue carrying out surveillance within the communities, but also mortality surveillance. We carry out mortality surveillance among the dead. So we take samples, especially from those who die within the communities, and analyze these samples to ensure that the death was not caused by the Ebola virus. So that will keep us more sure that we are safe. Apart from that,
if I could step in there for a moment, how do you ensure that the community is supportive and cooperative? Because you had a specific incident in Kasanda during this particular outbreak. You go tell the community, everybody knows, there is an outbreak here, people are dying of Ebola, it's a highly contagious disease, it can kill you. someone is buried and then people think, no, wait a minute. You didn't bury in accordance with how we should bury our person. We need to do something else. Or you have an incident, someone gets in touch or interacts with a patient, and the quickest solution is to run away, and a relative is saying, no, if they can't attend to you there, run and come here, we'll manage your situation. How do you get the community to cooperate, especially when you're talking about mortality surveillance? Is that what you call it? Yes.
Yes. And I was coming to exactly that. The other activity that will continue is risk communication among the communities. And just to let you know that at this point in time, the communities in Mubende and Kasanda are one of the best communities because they have had the experience, and this outbreak came to an end majorly because of their efforts. So many of our teams that will continue working with them will continue the aspect of sensitization door to door, including, of course, sensitization by the village health teams. But we don't want to limit this only to the epicenter districts. Like we said before, Uganda is prone to outbreaks, and it can happen in any other place. So this risk communication will be nationally, and wherever there is a challenge, we will continue with laboratory tests, door-to-door sensitization, and so on. But also the other activity that we shall be undertaking is infection prevention and control, majorly at the health facilities. Because as you are aware, usually when these outbreaks start, the people who are most at risk are the health workers. They get surprised, and then you hear, so we confirm a case, and the following number of health workers were exposed. So moving forward, we want to ensure that our health workers, first of all, are trained and they remain vigilant. This attitude of examining patients like we used to do before, without gloves and so on, has to stop. The health workers must be protected at any one time. So they need to have their protective gear on. Even if somebody comes with just mild symptoms, they need to be very careful.
They need to be suspicious of everybody, every patient they deal with. Is that what you're saying?
Including you, when you report to the facility. Yes, so we will continue with that infection prevention and control. But also in addition, we train, in this particular outbreak, we trained over 2,400 health workers. We want to continue with the training so that every district has capacity. Since we started having Ebola outbreaks, we have been having this measure of where we transport health workers from Gulu, from Bundibujo, from Chivale, those who have experience, to the districts that are running the most current outbreak. But we want to have capacity in such a way that if it happens in any district, the capacity is already there. And the health workers are able to respond with, of course, guidance from the Ministry of Health.
Okay. Let me quickly move to Dr. Nanyonja for a moment. You sit at the World Health Organization. There's some intriguing thing. Kasanda is Mubende, Kasanda, fairly rural districts. And how do you come to make a decision and declare that there is an outbreak in a particular area? And if you could allow me, sometimes my questions are very long, but please pardon me. I have been to the Ministry of Health, and I find they have a very interesting facility there. They have a large TV right at the reception of the ministry, and it's tracking incidents. Who has fallen sick of malaria, where are they, and what have they fallen sick of, how many have died. And sometimes you ask and say, really, in this country called Uganda, you're able to gather this data and relay it? How do you decide that this is an outbreak here and we need to announce to the world that there is an outbreak in Uganda?
Okay, thank you for that question. I think that what we need to know, first of all,
I need you to speak closer to your microphone, please.
what we need to know, first of all, is the source of this infection. And to understand, as the Honorable Minister has said, that this infection is in many places, in many, I'll call them animals or reservoirs, that are within the area of East Africa. So typically, a place will be having people that are interacting with some of these animals, could be monkeys, could be bats, or other primates that are infected, baboons that are infected with the Ebola. And then one person typically will pick infection, one or more from those infected animals. And they start falling sick. So they present to the health facility, or they are detected by the community health worker, the village health team, having symptoms that are typical of a disease similar to Ebola. So we have worked with the different countries, and they have what we call case definitions. How can a village health team member know that this person is having a disease that is likely to be Ebola or malaria? So that information has been given to these community health workers, and it is available at the health facility. So a health worker, competent health worker, or competent village health team member will see and suspect a case to be possibly Ebola or another viral hemorrhagic fever, and will cause a specimen to be collected and transported safely to a competent laboratory that does the testing for Ebola. There are also standard tests, PCR tests for Ebola. And once the test is positive, only one positive case in an area, you declare an outbreak.
What is the turnaround time for this declaration to be made? The process you're describing is long, but in a typical community,
yes,
one person will fall sick and die, possibly, and then another maybe, and then people begin saying there is a strange disease that is killing people.
Yes.
What is, ideally, what would be the turnaround time for this?
If we have a person that detects the case quickly, the turnaround time is short. But as you have said, typically one person gets sick. When there are 3, it is a cluster and it is suspicious. Within a week or 2, the investigation begins and the sample is taken. But once the sample is taken, it goes to the laboratory and the results are out within 24 hours.
If this person has already been buried, what happens? Unfortunately, they've passed on quickly and they've been buried.
Yeah, it happens sometimes that a sample is taken and the person dies before the result is out. And sometimes you find that maybe the person has not been even buried safely because the results were not out. But once you get the result and you declare the outbreak, because one case constitutes an outbreak, then all the investigation around that case begins to identify the contacts, to identify who else could be sick around the case, and then you really declare that that place is affected by Ebola, and all the intense interventions against Ebola begin.
Let me put this also to you. We're living in a world that is prone to outbreaks like this.
Yes.
I mean, the world is still trying to recover from the outbreak of COVID-19. We have Ebola, we have other similar diseases. And disease has become both political, economic, that when you're making a declaration here, tourists are canceling, businesses are floundering. By the time you come to that, there is the politics of it. What is the kind of collaboration you have with the ministry to say, look, we have a situation here, we need to do the declaration, but there are going to be political and economic ramifications?
Okay, Thank you for that. I think that you're very correct that outbreaks really have social, economic, political consequences, and all countries are aware of this. But we also have the international health regulations, whereby all countries have committed to transparency about any outbreak that occurs within their jurisdiction area, because we know that an outbreak in one place could easily be an outbreak everywhere. So there is a commitment to that transparency. Actually, we work with the ministry. The ministry does the confirmation, and they're obliged to inform World Health Organization within 24 hours of confirmation, so that the outbreak is jointly declared.
Okay.
So in this case, we want to really congratulate Uganda, because they were very transparent about this outbreak. Within 24 hours, they had already informed the World Health Organization, and its outbreak had been declared. Of course, when you declare, you make all effort now to control this outbreak, to limit, to mitigate the impact, social and economic impacts of the outbreak.
Thank you. Let me inform our viewers that this is actually a collaboration with many other media outlets. So this edition of the Frontline is being relayed not just within the family of Next Media platforms, but also other collaborating platforms, including Vision Group. We have some of their platforms relaying this show. We also have BBS also relaying this very show. And I have, for once, I think we should do this a little bit more. I have an audience in here in studio that is watching the discussion as it goes on. Let me move quickly. I wanted to let me come to the minister back for a second. The capacity. Previous outbreaks, you collect the sample, bring it, send it to CDC, Centers for Disease Control. We're waiting for results to come from labs in South Africa, labs in the United States, including previous outbreaks of Ebola in this country. Do you have now the capacity to do these confirmations within the 24 hours she's talking about? What kind of capacities do you have at the ministry?
Well, Ugandans have to know that we've come a long way. I think the last time we sent samples was the outbreak of 2000, which happened in Gulu, and it took us nearly a month to diagnose Ebola. Thereafter, Uganda has been continuously building capacity, and that is why you see the speed at which the country responds to outbreaks. We have built capacity, first of all, at the Uganda Virus Research Institute, where we are able to analyze for all kinds of hemorrhagic fevers. Even in one sample, we don't only look for Ebola. It is run for all hemorrhagic fevers. But we are also able to deploy...
Could you help our viewers, when you talk about hemorrhagic fevers, what are you talking about exactly? What are these?
Okay, to make it simple,
Yes.
when we check for Ebola, we'll also check for Rift Valley fever, Crimean Congo hemorrhagic fever, yellow fever virus, and so on and so
Marburg?
forth.
Is that part of it?
Marburg, yes, all those.
Okay.
So the common ones, we run for all of them, so that if one tests negative for Ebola, you don't want to miss any other. You want to be absolutely sure that when a sample is negative, it is indeed negative. So as I was saying, we have a huge capacity at the Uganda Virus Research Institute for that. We have capacity at our central public health laboratories at Butavika, but we are also able to deploy field mobile laboratories wherever we get an outbreak. Like in this last outbreak, we were able to have mobile laboratories in Mubende. Unfortunately, we were not able to use our isolation in Kasanda because by the time we constructed, there were no more cases, but we are going to have a field laboratory there. We had a field laboratory at Mulago. This is so powerful in such a way that it reduces the turnaround time. As we build capacity, we used to carry samples and bring them to UVRI. Now, if you have a sample all the way, Mubende is a little bit near. Let's take, for example, Gulu. You would need nearly 12 to 24 hours to bring the sample. But with the presence of mobile laboratories, you're able to test there and then, and your turnaround time is between 4 to 6 hours, and you're able to report. But if you're bringing it to UVRI, then we are looking at 24 hours. So having field laboratories or mobile laboratories at the epicenter really makes response very quick and a lot easier for the health workers. But Uganda has not only built capacity in laboratories. You mentioned something about being able to visualize every district on screen. We have what we call the Emergency Operations Center, where we receive all kinds of alerts. And alerts are like scares. Somebody is scared. I have these signs and symptoms. The village health team makes a report. And quickly, that report is relayed through to the EOC, and the case is investigated within 12 to 24 hours. We must know what is happening in any district. And this is not only about viral hemorrhagic fevers. We also do it for other diseases like malaria and many others. So we are able to monitor the country, all the districts in the country, every day on a routine basis. So if you ask me whether we are having a malaria outbreak, I can give you from my fingertips which districts are experiencing it. If you ask me about HIV, I will tell you which districts are having challenges. About TB, the same thing, and so on.
People who live in this country will find that hard to believe because they think systems here are not that efficient.
Well, Ugandans have to start loving Uganda. It is their country, and they have to love it positively, not negatively. So I welcome them anytime, and I will take them through these systems.
Dr. Nanyuja, let me come back to you quickly. And the many people who still believe there was no Ebola outbreak, and to make matters worse, I'll come to the RDC here. People say, Kasanda, Mubende, there is mining of gold there. There must be some other intentions that you guys were talking about.
Pardon? That government
wants to steal land, the other sinister motives. Yeah. Was there an outbreak? Some people will still continue to ask that question.
True.
Yes.
Yeah, true. Actually, should I come in?
Sure, please go ahead.
Thank you so much. It's one of the biggest challenges that we faced. We got all sorts of infodemia. Like, people have had quite a number of myths that were around Ebola. Even up to now, there are people who still believe, like you said, that actually Uganda never experienced Ebola. We came up with our own concoction. As government came up with a concoction, they want to spend taxpayers' money and the rest, all sorts of things. But it's only us, people of Kasanda and Mubende, who actually lost relatives, who have suffered to the extent that I remember you heard of a time when they talked about an entire town being deserted, and that happened. But this came about because of the various fake news that goes around on social media, unverified information. Sometimes you find that someone reports about something that they have not verified. So that misinformation is what caused us issues. And I'm glad that the minister has told you that we did a lot of community engagement. And it is one of the biggest things that the ministry plus the other partners invested in. And we moved door to door. We reached out to every individual, even during the lockdown, because some people didn't understand why they had to put Kasanda and Mubende, not Chegegwa or any other district under what? Under lockdown. So it's only us, those who lost relatives. It's unfortunate that it took some time. It took us a while. It took people of Kasanda and Mubende a while to be able to understand and feel the pinch. But when they felt the pinch, it really hit them hard. And that is when they actually came out. Because you remember, we got incidences of where people would run away from the ETU. in Mubende. Like literally someone just gets out and runs away. And the fact that some of them were late to have that communication with the community outside, they would hear all sorts of concoctions. They would hear all sorts of stories about government wants to take your kidneys, they want to take your organs. So in a way, some of them would reach there and run away. Their lives that were lost, that was very unfortunate, that some people would actually not have died.
You had people running to...
Yes.
You had people running to witch doctors.
Yes.
I thought in 21st century Uganda, witch doctors had significantly reduced.
Charles, you'll be shocked. It's us, most cases, it's even us, the elite. That us who call ourselves the elite, who actually run that side. I'm being honest with you. Ebola has taught me a lot. It has made me interface with very many people, and I get to understand, because believe you me, we are Africans and we have beliefs and traditions. That is why I want to thank the minister and the president so much, because during his discussion and during the times he would address the nation, he would actually reach out to the witch doctor. Actually, they call them traditional healers. Yeah, he would reach out to them, because we really appreciate that, yes, there are those ones who go there and then they treat them. But when it comes to infectious diseases, they needed to take a back seat and understand that we do not, some of these diseases, when a country or a ministry declares that there is an outbreak that is infectious, as Ebola is, then you take a back step and wait for science to take course, because all of us don't know these things.
You didn't have pastors offering to pray for these people and heal them?
Actually, we did. My RPC would tell you there are people we actually had to literally ambush and arrest, because they kept on holding prayers secretly in the villages. So it was, I can't tell you that it was an easy thing, especially in terms of community engagement, but I'm glad that eventually the people of Kasanda and Mubende listened to our humble appeal, though it took them quite a number of years. They started losing their friends that they use, especially the youth. Most of them, the biggest number of people that were really infected so much, when you look at the age bracket, most of them were youth, because of maybe sometimes the kind of social activities they encourage. But when they started losing, when they lost, there was one gentleman who died that I will not disclose. I've learned so much during this time of interacting with doctors, confidentiality. But there is one gentleman who died in Chikandwa that was so loved by very many people, in that they kept cleaning him, even when he was sick. They actually took care of him. So when he was declared, when he was confirmed that he was positive, and when he died, we realized that as our surveillance team was doing contact traces, very many, and even when you would go to the community, they would tell you, if this one has died, then take the entire village, because all of us interacted with him.
I'm looking in the audience, I'm seeing someone, I had a discussion about that very incident, actually in this studio, or on another show that I do here called NBS Face Off. We're discussing that gentleman with that incident, and he was reminding me, no, don't mention names, don't mention details. It's dangerous to mention those. But let me go to Professor. Professor, I want to, Professor Kirenga. Unfortunately, I should say, the significance of an outbreak is measured in numbers of the dead and those who get affected. Now, this particular outbreak, I think total fatalities about 57, that'd be the number? 55. If in epidemiology, would you call that a high number? Is that a low number? Where would you place a number like 55? And especially for a country that's reeling from 7 previous outbreaks.
Okay, thank you. I think the fatality rate depends on the disease. It differs from disease to disease. We know that Ebola is very fatal, and many people die when they are infected with the disease. Now, for this outbreak, the mortality rate of 55 out of 142 is lower than what has been observed in previous outbreaks, but also in other species of Ebola, like Ebola, Zaire, and others. Now, there are a couple of things which we...
Professor, could you speak closer to your microphone, please?
Yeah, there are a couple of things which we could think about why we observed a slightly lower mortality rate. And I also have to mention that earlier in the outbreak, the mortality rate was higher, but later it reduced. The health system responded with innovations that could have turned around reduce the mortality rate. I would start with the one from epidemiology, the surveillance, being able to identify these patients early, like it has been mentioned, surveillance, education of the communities, so people come early. Secondly, care was also improved using the usual care that we give these EVD patients, which is supportive care. Actually, in this outbreak, we attempted to provide intensive care to EVD patients. And that made the difference because most of these patients, they will die from dehydration, which shuts down their kidney, from, I don't know whether electrolyte will be understood, but derangements in the body. Most of those things could be reversed. Secondly, the minister implored us actually on day 11 of the outbreak to look into the issue of medical countermeasures. One of them was, are there any medicines that can be used to treat Ebola?
Press that microphone a little, where it bends there. Yes. Sure.
Yes, to treat Ebola. So when we went into the literature, we actually identified some interventions. For example, we identified the issue of what we call monoclonal antibodies. These are antibodies which we give you to fight the infection on behalf of the antibodies you would have had. We were able to bring in these monoclonal antibodies, I think less than 14 days from the outbreak. And we brought them here.
And you give those to people who are not infected, or you give them sick, to the sick? Okay.
We want now to neutralize the virus in their body, such their body can pick up. So we got these antibodies, and I remember colleagues from IDI driving the whole night to take them to I think, was it Kabarore? Yes, where very sick patients were. Secondly, there are other things which we also did. These ones, I don't think whether they made a big difference. We were able to identify survivors of Ebola Sudan with the help of the minister. We identified some of these. We consented them, and they donated plasma, and were able to make plasma here in the country at our blood bank. Also to mention, not to mention so many names, Dr. Lutwama from UVR.
To donate plasma means what? Because the
like
people we're speaking to may not understand what you're talking about. So how do I donate plasma, me as Charles Mwangusha?
No. Like if you survived from Ebola before,
yes.
You have antibodies to this species of Ebola. So we ask you if you can give us your blood such that we make plasma.
So plasma is blood?
Is part of blood.
Okay.
So I was going to give the example how Julius drove his own car on that day and was able to find these people, put them in his car, brought them to the blood, and we got plasma. Secondly, we also repurposed a drug which we are using in COVID, but which we knew works on what? On Ebola. And we deployed those. We are yet to finalize the analysis, but looks like these things helped. But the most important thing which helped is the care in the ETUs to reduce the mortality.
Now, I know what you're doing is you're a principal investigator for the Ebola vaccine.
Yes.
And we're talking about different tribes of Ebola. Ebola Zaire, Ebola Sudan, Ebola Bundibujo, Ebola what? I don't know if there will be another Ebola. It's the Americans who are complaining about how they name their hurricanes. Hurricane Catherine, Hurricane something else. Now, these different tribes of Ebola, the vaccine investigation, does it deal with a particular variant? Does it cut across? If you could tell us about that. And you are able to deploy a vaccine in this outbreak, and people are questioning, have you done the efficacy tracking to make sure that by the time you arrive at using it on human beings, you have done your homework properly and you think it's safe?
Okay, so the vaccines are specific to the species of Ebola. So when this outbreak happened, there were vaccines licensed for Ebola Zaire. And actually, one of the assignments we had was to find out if those vaccines could help here. We found out they were not going to help because these species, they differ. The Ebola Sudan we had here and the Ebola Zaire, where the vaccine was only 56% similar to the other one. So that 44% is so big that the antibodies or the immunity they were not going to work. So therefore, we had to look into vaccines for Ebola Sudan. There was none licensed, not even none which had reached a higher phase of study. So we had to evaluate early phase candidate vaccines, those ones which were coming up.
Is that being done locally? Is that being done externally?
It's a global effort. We worked with the national experts. We worked with the global experts to look into candidate vaccines. And were able to identify 3 good candidate vaccines which had good data that they could work. So we started working on the deployment of these vaccines, again, from day 11 of the outbreak. So you can imagine we have to identify the candidate vaccines. We have to write the protocols. Good enough, WHO had a generic protocol, which we had to adapt. We have to have this protocol approved. And we have to prepare all the logistics that needs the vaccine. So we are able to finish the preparation of all this in 9 weeks. And on 11th week, we received the candidate vaccines. At that time, the last potential people who could benefit from the vaccine were beyond day 15 of their exposure. So this, maybe I need to go back a little bit. The story is a bit long. That when we designed this protocol, we wanted the vaccine to go to the people who are most at risk. And those were contacts of people who had Ebola.
Okay.
So in the event that our protocol was approved for that, and these people are already 15 days, and we need to be a contact 21 days. So we're not able to vaccinate during the outbreak.
Okay.
No person received the candidate vaccine.
The World Health Organization and the ministry announced yesterday that this outbreak is over. Can I walk into a health facility tomorrow and say, please vaccinate me against Ebola because I drive through Mubende, Kasanda very regularly, and I'm at risk of contracting Ebola?
So first of all, again, let me go back a little bit. The vaccines we had were research vaccines. They were trying to generate data so they could be licensed. So you can't walk into a health facility and ask for the vaccine. However, on Monday, the minister convened a team of experts to think, how are we going to study these vaccines now that the outbreak is over? We came up with our ideas. Today, I think 1 hour ago, we have ended the global consultation on what studies should be done on this vaccine now that the outbreak is over.
Okay. Now, I just have one more question for you before I go to Honorable Winnie. I know you've been waiting for long, Honorable Winnie, to speak, but what are the ethical issues that come with deploying a candidate vaccine in the circumstances in which you deployed the Ebola vaccine in Mubende and Kasanda?
There are always ethical concerns in clinical research or in human research, and actually all research. And the whole thing is try to weigh the risk and benefit. We have diseases which come, like Honorable said, they come now and again, and we need a vaccine. So some people, and I have to mention, some people have to volunteer to help us study this vaccine. Of course, you know that before we bring this vaccine to humans, we have studied them in the lab, in the petri dish. We have studied them in what we call the small animals, the rats. We bring them to non-human primates, the monkeys and others, and we are convinced from the science that these vaccines work. But we need to test them on a human being. That human being must understand that this is a research, a trial. They must say, I want to participate. because I want to contribute to development of medical interventions. Once they consent, we tell them the risks and the benefits.
Okay.
Then we include them in the study, and no more ethical issues.
Honorable Winnie, let me come to you. One of the major questions that emerged or keeps emerging from the experiences we've had in the past, one, could this particular outbreak have been avoided? And then the measures taken, some people said this is radical. Radical is already an extreme. Radical, that you close off 2 districts, put them under lockdown. I should imagine what you're going through, having to drive through Kasanda and Mubende, going to Kasese every now and then, and wondering, for this stretch, there's a roadblock, you can't stop, and then you have to do consultations and say, can I actually drive through? Will I be allowed to drive through? Could it have been avoided, and were the measure, especially of a lockdown, in your view, appropriate?
Charles, I would like to, maybe as I answer your question, I would like to convey my heartfelt condolences to the families that have lost dear ones during this hard time of Ebola. And I would like to thank God for the lives that recovered. I know it is a hard time. It was a hard time for Ugandans because epidemics change lives. Epidemics change our normal setups. I know that, yes, the Ebola epidemic affected us politically, socially, and economically. It could have even spread because many people needed to fend for their families. Many people still needed to move. I remember when we were having the COVID-19 virus amidst us, I would not be allowed to move to Kasese, my home. If I'm in Kasese, then I'll not be allowed to move to Kampala. So I had to do a lot of negotiations, a lot of asking for writings from RDCs, and I know that it's that inconvenience that Ugandans really feel so sad about, because you sit home, you will not eat. Like the RDC was talking about young people who were at higher risk. It's true that many of the border cyclists are young people. This is what they do for a living. This is what brings bread at the table. So to say you are confining them to specific locations is you are confining their families to specific locations, and these specific locations may even mean death. So that is why many of the people would say, after all, if I sit home, I'm going to die. If I move, I'm going to die. So let what will come first come, because they have nothing to do. They sit home, they will die of hunger. They move, they will die of Ebola. So they just say, let come what may, I have to continue moving. But in the meantime, they are destroying lives of other people, because when you get the virus, you take it to your loved ones. In that case, you are putting the whole family at risk. I therefore would like to thank the Minister of Health for coming in very fast and ensuring that they save lives. But I also still want to note that we still have gaps in our health subsector. Take an example of what happened in Kambuga when the minister went there. If patients of Ebola, for example, and God forbid, were taken to Kambuga, and what the minister found there is what they find there, then we would be at a loss. That even some people can die of other diseases which are not even Ebola. But in this case, I also would like to thank those health workers who have put their lives at stake. I don't forget to, I do remember Dr. Lukuya, the late, who died in trying to save lives. I remember Dr. Yona Kule of Bundibugyo, who also died in trying to save lives. In Uganda, we also lost a doctor who died in Sierra Leone, Dr. Samu Muhumza, who died in Sierra Leone, also trying to save lives of Africans because of Ebola. I know that some
and we lost some lives during this particular outbreak of medical workers.
We lost lives of health workers during this outbreak. It's also unfortunate that some of those who have put their lives at stake trying to save lives are not paid in time. And yet they have families to take care of. The RDC will confirm that in Kasanda there were even demonstrations of people who had worked during the surveillance that they have talked about, which helped to calm the situation earlier than it could have been. Some of them are saying they have not been paid.
There's also a bunch of
yes,
security personnel from
yes,
both
even the security
army and the police who are
personnel
complaining
that
about
worked during COVID, even during Ebola. Some of them are still complaining they have not been paid. Circumstances like this make the fight a little bit harder. That someday, when again it strikes, you may not get people to show up and say, here we are to offer a service. The minister has been saying, love your country. I can tell you, Ugandans love their country. There is no beautiful country like Uganda, I can tell you, and we love our country. But we are sometimes let down by those who are supposed to help us. In this case of the Ebola virus, I think nobody invited it. And so you can't say it could have been avoided. By the fact that the ministry worked hard to ensure that they put a stop to it, though a lot had happened in the areas that were under lockdown, people were no longer earning. I know there is some level of poverty that must have hit the people of Kasanda and the people of Mubende, and it is understandable. Nobody invited it, so you can't say it would have been avoided, it wasn't anticipated. But the fact that we live near neighbors who are having it, because I remember when the Bundibujo strand came in, many people started thinking it was from Congo. We have had the Congo virus, which hit Kabale. We have also had in the past, in 2000 to 2001 there, we had again the Sudan virus hitting Uganda. Now that is the one that claimed the health of Dr. Lukwia. The Bundibujo virus, which hit us between 2007 to 2008, that claimed the life of Dr. Yona Kule. And, of course, the other health workers that have died because of this virus. I really want to pray that we don't get a reoccurrence of the same, because we need to keep working. In Uganda, you don't work, you don't eat.
Dr. Nanyonja, I'll be coming back to you at some stage. You said viruses live in animals. And you know there is a very popular stop in Mubende where most of the people who stop to eat meat. So I'm wondering how the transmission is done, but we'll come back to that after a very short commercial break. Let me hand back to Mildred.
Thank you very much, Charles. I could see that you're going back to your class to learn some components of your blood, the plasma, the platelets, and everything coming through. But also I love that you named these tribes of Ebola. I don't know how many more tribes we'll be able to have, but the fight is on. And for those who are watching us, the hashtags are Ebola exits UG and hashtag Ebola UG Ebola free. And of course, we want to say a special thank you to Bukede TV, One Luo TV, TV West, Baba TV, BBS, Sanyuka Television, Salam, UBC, who are as well broadcasting this. I want to just pay attention to a bit of the conversations that are coming through. The minister spoke about 2,400 health workers who are actually trained. And Chiwalabye Ronald here is asking, have you paid them all? I think that's a question that you will be answering at a later stage. Sech Toleko John also says, as the panel talks about defeating Ebola, the minister should think about the security personnel who were at the forefront of fighting the pandemic by considering something as a take-home. And so many other questions that are coming through, but we still have, like Ms. Phoebe did say, we still have some naysayers online who still think that it never actually existed, and this was just a hoax from government. But we'll take a very short break, and when we do return, Charles will be taking us on with more of the questions to the panel, and we'll also be taking on some of the questions that are coming in online. Once again, the hashtag Ebola exits UG and Uganda Ebola free. Let's get back.
Yes.
On the road. The life of Muvende is there. No, everything. Chicken, they sell chicken, they sell everything.
Okay, we'll be getting back in just a bit. All right, welcome back, and thank you so much for keeping it right here. We are not only at NBS TV at the next conference center, but we're also broadcasting live on Vision Group, which is Bukede Television, One Ruo TV, and TV West, Baba TV, Mweva Leino, BBS TV, Kwetulinyo, Sanyuka Television, Salam TV, and UBC TV that are broadcasting this. Another question as we get back to you, Charles, and the distinguished panel. Marvin Juko is asking, what are the post-Ebola outbreak measures the Ministry of Health is putting in place to prevent a reoccurrence? I think the minister will be addressing that. Of course, Sech Toleko is also asking about paying the security. Sometimes when we are talking health, we are only thinking about the health workers, and yet there are other frontline workers who need to come through. And as well, also on the payment of the other health workers who have been trained. Let's continue with this conversation. Send in your questions on hashtag Ebola exits UG and hashtag UG Ebola free. Let's get back to you, Charles.
Thank you, Mildred. And to our viewers, you're still watching a very special edition of the NBS Frontline. We have a town hall, an audience in studio here, and we also have the partnering, the media partners from all those other outlets that are sharing this edition of the Frontline. And my panel, let me remind our viewers again that we have with us the Minister of Health, Dr. Jane Ruth Acheng. We have Professor Bruce Kirenga. He's the principal investigator of the Ebola vaccine trial. We have Dr. Nanyunja Miriam working with the World Health Organization. We have the frontliner, the Honorable Winnie Kiza, and of course the RDC for Kasanda District, Phoebe Namulindwa. And we're discussing the end of the latest Ebola outbreak in Uganda. I need to be careful about some of these things. Why don't you first answer the questions from the viewers that came in online? So, Honorable Minister, I think I want to start with you. I have been receiving complaints. Yesterday, when you're announcing the end of this outbreak, and then you had a discussion on Spectrum, Radio 1, I had that discussion on many other media which were reporting the story. Someone called me and said, but look, we are not medical workers, but we are called in as a special team to provide security. We are from the police, from the UPDF, and other sister security agencies. We are not paid, and yet we're exposed. What does the minister have to say about that? And two people have asked that question.
Yes. First, allow me to start by appreciating the uniformed personnel who we actually refer to as frontline responders. They do an extremely good job, and whenever we get an outbreak, they are available to support the Ministry of Health in the response against these outbreaks. And in this particular outbreak, I want to deeply appreciate them because they are the ones who run what we call the restricted movements that you people are referring to as the lockdown. It wasn't really a lockdown because within the districts they were free to move. It was only out and into. That is why we call it restricted movements. Now, whenever we have an outbreak, we don't only respond as the Ministry of Health. It is a multi-sector approach, and many ministries, departments, and agencies come in. So we have Ministry of Internal Affairs coming on board, we have Ministry of Works coming on board, and many others, under the leadership of the Prime Minister. And the Prime Minister coordinates the various ministries. So what usually happens, because in Uganda we don't have budget lines for outbreaks, the various ministries request for funding to cater for their interventions, including their workers. And so, under Ministry of Internal Affairs, the uniformed police are actually supposed to be given their allowances. So I am hopeful that Ministry of Finance gave Ministry of Internal Affairs some money to cater for this police. I will follow up and inquire to find out. However, there are those who come in as medical workers because they are medical workers either in the police or in the UPDF. And when they come in as medical workers, then what Ministry of Health does is pay them a risk allowance as medical workers. But we don't cater for their salaries because their salaries are already
Still
under
coming
their
from the
different
mother ministry.
organizations.
Okay.
And if we are deploying them from one district to another, then we also give them what we call a per diem, because you have to look for where you can accommodate yourself. So the ones who are health workers were catered for under the Ministry of Health, and we did pay them. But the ones that took care of us during the restricted movements, I will inquire and get back.
Okay, actually the complainants largely, I think the two people who sent messages and the other people have been complaining are largely from those who helped to manage the restricted movements. Maybe the RDC would like to add something about that group of people?
I also want to add a voice to what the minister said, because in Kasanda, I witnessed this, because the payment was done by police itself, and it was under the RPC, the regional police commander. He was actually camped in Kasanda. And those that were deployed, because being that it was a restricted movement, and we are under lockdown as Kasanda, we had to get the enforcement that we had wasn't enough. So the IGP plus the minister actually sent us enforcement from other areas. And I witnessed that being done. Unless there are those few, just like you heard about the VHTs, the village, the people who helped us with the village health teams in Kasanda that put up what Honorable Chiz has called a demonstration. I think I reliably explained, if you can allow me, highlight on that too, because this was done when the minister came to Kasanda. Our biggest challenge was, being that we're a young district, our biggest challenge was with capacity. So she reached out to Africa CDC and other partners and asked them to train more
VHTs.
1,000. Actually, it was 1,000 VHTs. But remember, it was not only Africa CDC. Other VHTs had been trained by other organizations and other partners, development partners that had already trained them. Now, when Africa CDC came on board, it trained 1,000, and those were the ones they were responsible for. But we had other village health teams that were doing that we've been using and that had been trained during the process. Now, the challenge came in when some of these, the concerns we got were in terms of the numbers, because this payment goes directly on their phones, the registered mobile numbers. And the challenge is there are those ones who have phone numbers that are not registered in their names. And when Affinet is under doing the payment, and when the money was wired, some of the money is bounced. And those lists were sent back for the sub-county supervisors to be able to rectify and look for these people so that they can get paid.
Okay.
And that was
I think
explained
that's
to them.
fairly well answered. They'll pick it up. Honorable Minister, VHTs do a wonderful job. I can attest to that. But they are largely not provided for. They are volunteers. You don't have them in your system. They help with your surveillance that you're talking about and that tracker that you do at the ministry. But I think they need a little bit more attention. They need to not work just on the voluntary support of organizations that come in as and when. Balancing an outbreak, restrictions, the minister wants to call it restricted movement. The president told us it was a lockdown, and then the announcement was a lifting, extending lockdown, not restricted movement. Balancing outbreaks, the management of outbreaks, restriction of movements, and the rights of the people. In Mubenda and Kasanda, you really did harass border riders. You gave them quite a bit of hard time. How do you strike the balance? They needed to survive. We're not a DC. I'm asking you.
Thank you,
Yes.
thank you so much. The issue is, you remember initially they had, there were cases that were exported from Kasanda, and because when you look at the cases that were in Kampala, some of them, these people came from what? From Kasanda. And how they traveled, of course, they used private means, others used taxis and the rest. But when it came to the border restriction, it was more or less movement, okay? Carrying, like having a person carrying someone on a border who might be a suspected or a contact to a confirmed case. So now when this was done, with the wisdom of the ministry, they felt that it was not only up to them, but we needed to ensure that you do not carry, because as a border person, I might not know whom I'm carrying or taking to a different location. So if you are limited and restricted from carrying passengers or carrying people on your border, then somehow we restrict the movement of people. But the challenge that was there is, of course, initially it was completely, they were not supposed to ride anything. Then later on, the ministry accepted, with the guidance of the president, that they are allowed to carry cargo. But there is nothing as hard, like the Honorable Kiza has said. Most of the border people feed from hand to mouth. Most of them survive on the daily income they get. And as I was interacting, maybe something that we did differently in Kasanda is that we incorporated, on our task force, we incorporated the youth, because we realized that the people who are giving us most of the time had time, and then the ones that were being affected, we incorporated the youth. But now the challenge was in making them adhere, because there is nothing as hard as restricting someone who thinks so, like the only way they can survive or fend for their families is through the border. So today, if I don't work,
but
then
you
that
appreciate,
means I'm not going
you
to
appreciate,
eat.
Madam Aradisi, that border has been the most restricted over the 2 years of COVID-19 lockdown. They were the most harassed, most restricted, and they sit at the bottom end of the economic ladder. I want to put this to Dr. Nanyunja and ask, are lockdowns an effective method of containing outbreaks? Because the question that emerged both during the containment of COVID-19 and now Ebola is, you're preventing one disease. What other death? What other suffering? What else do you cause by lockdowns and restrictions of movement?
Okay, thank you for that. I have to, first of all, say that there are different mechanisms that can be used for disease control, for epidemic control. And depending on the disease that you are dealing with, you can apply several. Some diseases we have vaccination, and as effective vaccine can help to control the disease. But there are diseases like we saw with COVID and now with Ebola Sudan, where there's no vaccine. And where there's no vaccine, you have to use other public health control measures to try and control the disease. And in a disease like COVID or Ebola, where there's a transmission through contact with infected people, you have to limit contact. And we saw in this Ebola that people were refusing to adhere to this measure of reducing contact through either social gatherings or travel on the border, travel in the taxis, and the disease was even spreading beyond the borders of Mubende and Kasanda to other districts through this kind of travel. So depending on that context, I think restricted movements was an effective intervention. So it can be used in different contexts based on the disease and the availability of other public health measures, and also if there's no other effective means. This one helped us really to bring control, to get control of this outbreak.
Someone would ask Doctor and say, why, for example, didn't the ministry announce a lockdown in Kampala. I mean, we had an incident in I think, Gayaza, Wakiso. We had an incident there. We had an incident that crossed to Jinja and then to Masaka. Why not Kampala? Why just Mubende and Kasanda?
Now, in Mubende and Kasanda, the disease was quite spread out in several sub-counties. And so there were many people that were at risk and many people that were exposed and crisscrossing the districts with high risk of transmission. Now, in Kampala, when the cases came, we tried also another restricted movement approach, which was quarantine. We tried quarantine of the exposed people because within 21 days after exposure, you can develop disease. So we would quarantine the people that are exposed and support them or review them daily and see who gets ill, and we remove them from the quarantine to the treatment center. So that was another way of restricting the movements of the exposed people so that they don't move out and spread the disease to their neighbors and loved ones.
Okay. Professor, let me come to you for a bit. This naming of disease, Ebola Bundibujo, Ebola Sudan, Ebola Zaire, what traumatic effect does this have? And just traumatizing the entire population of Zaire, the entire population of Sudan, or Bundibujo, that they represent a disease, from where you sit.
Yeah, there
pull the microphone
could
closer.
be some stigma associated with this nomenclature. But what I have to say, there is actually a method and there are principles of naming these viruses and bacteria, let's say microorganisms. It's not actually as random as it looks. So we have a way we name these organisms. In long time, they were named after people who first identified them. And through deliberation, people said, as one person, it's very difficult to characterize an organism. It looks simple, but it's a complicated process. Then we went into these organisms actually have biological names, but those were difficult. So then there is also associating them with regions or areas where they have been identified. Actually, earlier today we're actually discussing, instead of saying Ebola Sudan, maybe we could say Ebola identified in Sudan, because it's not Sudan Ebola.
You had a whole debate about naming COVID-19.
Actually, the meeting
you had a whole debate.
Meeting, yes, we were discussing that.
COVID-19, some people wanted it called the China virus. And then there was a
that.
huge debate.
Yes.
And then settled for a figure.
Yes.
COVID-19. What about these other outbreaks?
Yeah. So anyway, but also as I told you earlier, these viruses, depending on where they were identified, they're actually specific things about them and where they were identified, which we want to keep. That's why you see we cannot just call it Ebola X. We are saying maybe we say Ebola of Sudan or Ebola of Bundibujo, such that we don't say Bundibujo Ebola, something like that.
How does that help? You're into vaccine research. How does that naming help in your research initiatives? Is it of any particular value? And then the other question I would like to put is why Kasanda Mubende, Ebola Sudan? We know we also have a variant called Ebola Bundibujo. How do the viruses choose where and when to break out?
Has the answer. I was avoiding some of those things. There's something which we call phylogenetics. That virus, which is identified in Sudan, we actually know where it came from and how it has been evolving over time. So we want to keep that. It may not affect which vaccine we make, but there's that phylogenetics. Now, coming to Kasanda and why didn't Kasanda get Ebola, which is closer, and to go to Sudan? still also it goes into that evolution of these viruses and the reservoirs. And maybe, I don't know how I can summarize this. The natural home or reservoir of the Ebola virus are the fruit bats. That
Pardon?
word fruit, a fruit you eat, the fruit bats. Now, as you know, these fruits, where they attract many things. They will attract the birds, they will attract the monkeys and other primates, they will attract other animals. So that interaction there creates that link from the wild to the human beings and fuels it. Now, recently there's something emerging. I don't know how I can put this. Maybe I don't know who may put it better. The issue of persistence of the virus in the body, because it can bring a bit of stigma. It is a third way that these reservoirs are coming. So meaning that there are sites in the body where whatever we do, the immune system and the drugs we give, the virus will remain. Some of those sites.
The survivors in Mubende and Kasanda have formed an association.
Yes.
I don't know how much that helps. They said, we're survivors of this. I had someone on radio yesterday saying, we're survivors of Ebola, we have formed an association, we're suffering stigma. But from a health perspective, how does that identification of a group of former victims help from a disease perspective? Is it of any value? No, not actually
Of course,
helping.
it is any value. People affected by any health problem or any problem, when they come together, they can defeat the stigma, they can help each other, counsel each other, they can share experiences. Okay? And even when we guys health workers, I'm happy they have formed it, then we know we can access them using that group and give them information. Because we have information, like the issue I'm telling you of the persisters, as the third way, the virus has now jumped from the bats, it is now into the primates, and now it is creating a little home also in the humans by it persisting in these sites.
Okay, one last question before I go back to Honorable Kiza. What long-term effects, and I know the doctors here could pick it up, what long-term effects persist after someone has recovered from Ebola? I don't want to go back to what the gentleman was saying yesterday, what he has suffered or what happened to him. I don't want to go into that. But the disease is over. You've declared that this particular outbreak is over. The people who had been victims, a large majority of them survived and recovered fully. But are there things that linger after suffering a disease like Ebola? Dr. Cheng, Dr. Nanyunja? Someone could pick it up?
Yes. We have seen that many of the survivors sometimes have some small problems, sometimes big problems. They tend to have small side effects, feeling unwell, joint pains, a common problem, especially the back pain. Then some of them can have challenges with muscle pains. Others can have challenges with different body parts. But we also note that in a few instances, the virus can hide within the eye there, and it can affect the vision of the people. Sometimes, in a few people, it can go to the brain as well, and you have some brain complications. So it is very important for these survivors to have this group association and be supporting each other, but also to go back for their follow-up visits, for regular checkup, to see if they have any of these, and for getting support to manage several of these.
Honorable Winnie Kiza, many people are concerned about the Mubende Kasanda outbreak. Zooming in on these particular geographical areas, other people will read it as communities. Do you think, from where you said, that the restrictions could have been handled differently? Could have been handled better?
Well, I'm not a health worker. As a politician, I would say they should have left people to move, But I also know that as politicians, we need people who are healthy. We need people who are on their feet. And so I hate it when we are fighting epidemics and we beat up people. I don't like it, because that is not the best way to handle human beings. There you get into conflict again with the issues of human rights. But I also know that some people can be a little bit stubborn. But also the stubborn nature of those people depends on what is at stake. Like I said at the beginning, if someone is entirely dependent upon a business that will allow them to move from one place to another, and you restrict that, they will definitely be stubborn, because there is no way they are going to survive. So what is at stake will compel someone to say, whatever comes, I'm ready for it. So somehow explaining this information to people is very, very important. Sometimes there is little information that is given to people. Before they know it, they are being harassed, they are being beaten. Even the people who are beating them are not telling them why. I know that if information is given to people early enough, and possibly through their leaders, then they can be in position to understand and find some other ways of survival. And you know, because Kasanda and Mubende had issues, had issues of gold mining, that is why, and you saw what happened during that time. There has been issues of land grabbing. So for people to come up with those issues, it's because of the past experiences that they had, that they would say, no, I think they now want to steal our land when we are under restriction. Maybe they now want to steal the gold when we are under restriction. But it also goes to trust. If they don't trust their government, then they will say what they will have to say. Now, it is entirely up to those who are in question to come up and say, I think it's not what you are saying.
Okay.
Now that the Ebola has been kicked out, I want to say that the people of Kasanda and Mubende are free to do their businesses as they would have loved to do it. Also, I would like to
they got an early Christmas present, because they were declared free on the 17th of December.
Yes.
Just before Christmas.
Yeah,
so.
but of course they hadn't done much to prepare for Christmas. Under lockdown, what do you do to prepare for Christmas? You know what people do during Christmas. There will be those who will need clothes. There will be those who will need meat. Some families have meat only on Christmas. So if you have not allowed them to move and look for that meat, it means they will have a very cold Christmas. So really, yes, the announcement came in early enough to enable them celebrate Christmas, but at the same time, it might have come a little bit late for them to look for what it takes to have a very wonderful Christmas. But my happiness is that they can now move freely. My happiness is that as a country, we have been pronounced free of Ebola. And I just want to pray that we continue like that, so that we can be free to do whatever we want to do, so that we can be free to move, we can be free to do our businesses, we can be free to recover what we lost during that time of lockdown and restriction of movements.
Henry Baguma is watching us and says the minister and your team should be given medals. I had someone else propose that, I think already yesterday, and saying Heroes Day, June 9th, that some of the people who should be recognized are the people who are at the front line of the fight against Ebola. There is, that's from Henry Baguma. There is Laban Mohawe is watching us from Chitagata, and he says, congratulations to you and your team for a job well done, and he thinks you should be voted the best minister. I don't know where those awards are. Maybe Laban is organizing them. I don't know when it... Yes?
Charles, maybe before we also continue, to the people who have come up with an association of the Ebola victims, I know many people who have suffered certain ailments and have come up with associations. It has helped in talking about the disease. Like those who have HIV, those who are positively living and are talking about it, it helps when someone is talking from a point of, I have been through it or I'm through it, and I know you can still survive. I know you can still support your family. Those who have come up with the association, I think that is one of the best ways through which we can talk about the disease, and possibly the best way through which they can support one another and get information firsthand from those who are concerned. I don't know whether now you will be going back to treat those other minor and possibly major symptoms or outcomes of the disease. I know those that have an association of people who are living with hepatitis B. It is helping them to understand how to manage the disease, how to even take medication, whom to contact in case of information. So these are people that you can give information, possibly they can be able to now talk to the population and let these other stereotypes and stigma lessen in the population.
Okay, I see the minister here. Minister, I'd like to come in, but I will smuggle in a question that is outside what we're discussing. And this is a question regarding what Uganda and the rest of the world have suffered over the last, since December 2019, the outbreak of COVID-19. China has opened its borders, removed restrictions after running the most restrictive. I think China, New Zealand, Australia ran some of the most restrictive measures to contain the outbreak of COVID-19. Countries across the world, especially the developed West, have been responding. Has Uganda responded? Are there restrictions for people arriving in from or going to China? That's that.
Before I come to that, let me just reassure my sister here and those who are listening that we never let go of survivors for several reasons. Earlier on, you heard from Professor Bruce that we were able to get some blood or plasma from those who survived in Luero, and it was very helpful. But we walk the journey with survivors for many years, and they have many programs, including being monitored, because some of them still have the virus hiding in many parts of their bodies. So we continue, doing analysis of semen for the men until they turn negative. But it is not that they have active Ebola. No. So we take care of the survivors, and we keep the inventory. Even after 10 years, we will still need you. So they are very valuable people.
There's someone who sent a question here, actually, before you go to the China question. Someone sent a question and asked that what lessons do we pick from responding to outbreaks like Ebola at a technical and policy level? What lessons?
There are very many. If I start running through them, I may not finish. But the most important for our country, really, is that we need to have readily available resources for epidemics. Our country is prone to epidemics. And this idea of, you wait until an epidemic comes, then you request for a supplementary. Honorable Winnie knows this very well. And it takes so long to come. That one does not favor a quick response. You want to be able to deploy people to the field as soon as an outbreak is declared. And from where we have come from and the lessons we have learned and the systems we have built, I think that is the weakest link Uganda has. If we can address that, Uganda will be good in so many ways to handling epidemics. There are many other lessons I won't go through now. That was the most important. I want to go to the China.
I can see WHO wants to add to lessons.
Yeah, thank you, Charles. I think that one of the key lessons also we learn as government of Uganda, as WHO, is the need to support more research. And as a country, I think there is need to put more money on research, because it is much easier to control outbreaks that have the medical countermeasures, the medicines and the vaccines. Then you wouldn't need the restricted movement so much if you have these products. So it is important that we engage more in research to find some of these products that we can use.
People would ask a question and say, well, you have had 7 outbreaks in 20 years. Out of these 7 outbreaks, the latest one affected in total less than 200 people who got infected. Some recovered, some died. Research and investment in vaccines is heavy investment. The question is it worth it? What do you do now that this outbreak is over? Like Professor told us, the vaccine was only being tested on Ebola Sudan, but you have other variants. So what happens to that effort, to that initiative?
I think that where we have had more bigger outbreaks due to Ebola Zaire, and a lot of effort went into research on vaccines and medicines that could treat Ebola Zaire, and there was significant success. But because we had not had the Ebola Sudan outbreak in more than 10 years, I think it was fairly neglected. And so that's why we get into this outbreak at this time, and we don't have any medical product to use.
Yes, to reinforce on that question, Addis, before you come in, to reinforce on that question, when we had Ebola Zaire, there was an effort to vaccinate frontline communities, those who share a common border. But with a country as disease-burdened as Uganda, you're losing many more lives to malaria, for example. You're losing mothers in labor or in labor. You have a lot of NCDs or non-communicable diseases that are prevalent. The question is, how do you strike the balance to say we need to make this investment in this vaccine research instead of putting those resources, which are not sufficient, as Dr. Cheng will tell you, into some other thing that is some other disease that is a bigger burden to the country?
Charles, outbreaks like Ebola bring down economies very fast, extremely fast, because immediately you declare the tourists will, postpone their coming, and your neighbors will be scared that you're going to export Ebola. So trade with your neighbors will also be questionable. Within the country itself, people are scared of doing businesses and moving from one district to another. So when such outbreaks happen, you need to look for a way of in future ensuring that it does not happen. Because malaria is known, whereas it devastates the economy in that it actually impairs people from doing their normal duty. But it will not stop tourists from coming in. It will not stop trade from going on. So investments in having our own vaccines or having vaccines readily available is extremely important, because the amount of money you spend in a very short time to control the epidemic and the amount of money you spend to bring other people in to support you is enormous. So having these medical countermeasures is 100% recommended. So there is no question about doing research. It must be done.
Okay. Talibita Moses is congratulating you, thanking you, saying that beyond the pandemic response, you must be rewarded for the Tobacco Control Act, which you also defended in court. And also that lockdowns benefited reductions of shisha smoking. I don't know if that ban is still on. But he adds something and says, what happened with the Health Laboratory Services Bill? Because 90% of health seekers need lab tests. Through epidemics and pandemics, what of the national health insurance? Because catastrophic expenditure has left many detained, yet it's illegal. Where is the patient's rights bill? So these are a number of bills.
Which patient bill?
Yeah, a patient rights bill.
The
I think he's
rights
asking for
bill.
one. If you don't have one in draft, he's asking for one. He's talking about Health Laboratory Services Bill that you should put in place, and then talking about 70% of health seekers need lab tests. And so, through epidemics and pandemics, of the national health insurance because of the cost of treating. But we're talking about, Moses, we're talking about Ebola, and I don't think any patients for Ebola were detained. I think many patients were detained during COVID. So maybe we'll reserve that question and the answer for another time. Phoebe has been itching to say something.
Thank you so much. I just wanted to also add on to the lessons that some of the things that we need to do better, and I'll look at it in a political perspective, not one doesn't need to stop. Like, when we have outbreaks, we tend to intensify the sensitization and educating the community about some of these things. So I want to encourage the ministry, on top of also other agencies that work around this, to ensure that we continue informing our community about some of these diseases that are bound to reoccur as we put up other measures, but we need to ensure that we constantly have those messages running so that when an outbreak, in case we have a reoccurrence of an outbreak, then people can we don't start running up and about, putting more information out there. If I have some little information, like we have the village, the first health centers that are at the village, if we continue having this kind of message being passed around in the communities, then somehow we would be able to detect some of these outbreaks earlier.
Someone called Beyeza Rogers, he runs a church in a place called Chibengo, Rivers of Joy. He's emphasizing, he says the minister did not respond adequately to the question of VHTs, the work they do and how important they are, and how your ministry looks at them to give them some support. Please talk about VHTs.
So, Charles, I have nearly 3 or 4 questions running.
Sure, I'll give you time to answer
China
them.
and COVID. I don't know which one you want me to start with.
I need answers to all the questions. So start with the VHTs, then go to China and COVID.
Okay, let's start with the VHTs. Personally, I would love the VHTs to be paid because there is a limit to voluntarism. Since the year 2000, when we started the village health team concept, they have been largely voluntary. I say largely because they are not paid an allowance on a monthly basis. However, they are paid for whatever intervention they undertake. And that is not a reliable source of income, because if you're not trained or you don't undertake any intervention, you don't receive that small allowance, and yet we expect you to continue with the activities within your village. Now, the challenge has been that the current numbers of VHTs is really huge. There are over 195,000 VHTs, a lot more than the health workforce, and of various age groups, ranging from 25 up to over 80 years old. And we value all of them, and we want all of them to continue working. But it may not be possible to pay all of them an allowance. And that is why we came up with the Community Health Extension Worker Policy and Strategy. And in there, we are looking at 2 village health teams per parish who are intensively trained for 6 months. And these ones will continue to work with the village health teams to render door-to-door services. And these 2 will be held responsible for the entire parish where they serve, and ensure that they propagate knowledge through the existing village health teams, who then move door to door. But they will also be responsible for record taking, for follow-up of the households, for reporting on time, and also for retraining the village health teams. That would be an easier way of payments that would allow us to have nearly, if we have about, I don't know how many parishes we have in the country, and we multiply that by 2, it will give you some idea of how many VHTs could be paid.
Okay.
And we are looking at them being paid a monthly allowance so that they are motivated to do their work. Now, this policy and strategy were developed already. Ministry of Finance completely understood, and they understood the impact it would have on our health system. However, we are still having discussions on the source of funding and how it can be given to the health sector. But of course, also subject to cabinet approving. In the interim, we are working with partners who have agreed to support training and paying of allowances. And so we have started the pilot. We started in eastern Uganda. We have trained community health extension workers in Mayuge. We are already following them up and seeing the impact of what they can do on the ground. And we shall continue to the various other districts. Now on the issue, China and COVID. Yes, China is not having a very good time right now with the rising numbers of COVID cases and a new strain, XBB.1.5, that has actually spread to other countries. And you asked a very good question. You said many of these countries have put in place interventions, restrictions. If you're coming from China, you test. What are we doing in Uganda? Charles, you will also recall that in Uganda, we carried out several interventions to ensure that the COVID cases go down. We had very serious campaigns of vaccination. And a good number of people responded, although right now people are hesitant to get vaccinated. I would still appeal to the general population to get vaccinated. We also continue
vaccinated for COVID-19?
Yes, vaccinated for COVID-19. We have vaccines in all health facilities that offer vaccination. It is important to get vaccination. That is one of the challenges that China had, because when they started vaccinating their population, the population became resistant. So the coverage was very low, and in addition, they restricted movements. One of the small benefits we had from Omicron was that it spread the entire country. And so we also developed some immunity, although it wears off. So right now, we are carrying out intense surveillance within the population, but also monitoring those who are coming in. If you're not vaccinated, you must do a test.
So what you're saying, Honorable Minister, is that there are no specific measures regarding China arrivals?
If they are vaccinated, fully vaccinated and boosted, and they come to Uganda, we will allow them in. If they are not you have to show your vaccination certificate. If you are not vaccinated, then you have to do a test 24 hours before you come into the country.
Okay.
That one is what is known at the airport, and there are health workers to enforce that.
Okay. Is that restricted to China arrivals, to every arrival?
Every arrival into the country.
Those measures still exist?
Yes, including the Ugandans. If you have to travel, you must be vaccinated.
Okay. Okay. Let me thank our partners,
so
broadcast partners.
What about the last countries?
Yes,
the
I'll
last
come to you
questions?
in a minute. I'll come back to you in a minute, because I also need you to make your closing statement. We have about 3 minutes for everyone to say something. So UBC TV, Bukede TV, One Luo, Salam TV, Sanyuka TV, BBS Terefina, Baba TV, TV West have all been running this broadcast, and we thank you, both the broadcasting houses, but also the people who are watching using those channels. So, Honorable Minister, if you could invite the panel here.
So in 30 seconds, I want to reassure Ugandans that we are working on the National Health Insurance Scheme bill, and perhaps this year we shall make progress and it will be out. The National Health Laboratory bill will be incorporated into the National Public Health Institute bill that will cover for surveillance, because public health laboratories are really part of surveillance of public health diseases. Now, regarding the Patients' Rights Bill, we already have this. You cannot talk about patients' rights without talking about health workers' rights. If you emphasize patient rights alone and you leave out the health workers, then you will punish the patients. So both have rights.
Okay.
And we already have these documents clearly spelling out the rights of patients and the rights of health workers. There is no need for a law in that.
Thank you.
As I conclude, first of all, allow me again to make this appeal to Ugandans. Whereas we have declared that Uganda is now free of an outbreak of Ebola, I want to remind you that COVID is still with us, so get vaccinated. Let us not spoil all the gains that we have made with the COVID pandemic. But also to continue to appeal to you to remain vigilant, because these outbreaks occur in the communities, and you live in the communities. Look around in your community every day. And if there is an unusual event that is taking place in your community, please do report. We don't want, again, to have an outbreak announced like we did with the Mubende outbreak 2 weeks after the first case. We need to be as quick as possible so that we control these outbreaks in the shortest possible time.
Thank you very much.
But also to let you know that once we start the vaccine trial, please be a volunteer. I thank you.
Thank you very much, Honorable Minister. Ken Intaro, I've seen your comment here. Ken Intaro thinks all those who are on the front line should be given an appreciation package. If that is not possible, at least give them medals. And then he's also asking about the journey on creating vaccines, generating vaccines locally.
The president promised all the health workers medals.
Medals?
Those who are, yes, those who responded to the Ebola. He said it.
Okay.
And I hope they will get it.
I think many people will be asking that the medals come with something. The president understands the language. Doctor, can I have you come in and in 30 seconds? The minister took more than 30 seconds, but you should take 30 seconds. Dr. Nanyonja.
Yeah, thank you very much. The people that are watching this session, I want to say that Uganda has done a great job in this Ebola outbreak, containing it in the shortest time possible. But I call upon each one of us to be on the lookout and make sure that if you see any unusual illnesses in the community, you report it so that it can be investigated. We rule out Ebola, but also we find out what else is going on in the community. We would like to have more healthier communities by detecting outbreaks early and managing them quickly. Thank you.
Professor Kirenga, could you come in, last statement from you?
Yeah, thank you. My last statement would be that we are going to continue Ebola research, and if we finalize the protocols and we invite the population to participate, to volunteer, we really request that people come and volunteer so we can build this science. Thank you.
Thank you. Frederick Dongo Shema, I have seen your question, your comment rather, but we can't take it now because you'll not get an answer. Our time is out. Honorable Winnie, closing statement from you.
I want to congratulate Ugandans and the Ministry of Health for going through this with huge success. And I once again would like to convey my heartfelt condolences to the families that lost their dear ones. And of course, I will say that to the people of Kasanda and the people of Mubende, you just need to be in their shoes to understand why they had sentiments about the lockdown, and of course why they even had some other feelings imputing ill motive about the reason why there is lockdown and restrictions. I think when people cease to trust the leadership, then they will have every reason to question every move that the leadership proposes. But all the same, I want to say congratulations, and I want to say well done, the Minister of Health. To the Ugandans, we can once again move freely and visit our relatives and friends, be able to move freely through Mubende and Kasanda as I go to Kasese. And I continue to pray that the situation remains as it is now.
Thank you. Paul Emodu would have wanted to be part of the town hall. Unfortunately, we didn't inform him in time. So, Paul Emodu, your concern is noted. Kenneth Lukwago, you're also watching us. I think your question was put, even if we didn't attribute it to you. But thank you. Bernard DC, you have the last word.
Yeah, I want to take this opportunity to thank the people of Kasanda and Mubende. No one understands what we went through. I want to thank you so much, all of you who sacrificed your time, the resilience, and the time to endure what we went through. I want also to encourage you, like the rest of the speakers have said, to encourage you and always inform you that let us know in case of any odd or weird kind of situation that is in your communities. The surveillance is still ongoing. The VHTs are still working. So please let us know in case there is anything that is suspicious so that we can be able to respond just like we did. But otherwise, thank you so much. Asante sana. Mwebale nnyo bannakasanda na bannamubende.
Thank you very much to the panel. Thank you very much to our partnering broadcasters. I need to mention once again UBC, the Vision Group family. They gave us TV West and One Luo, BBS Terefina, Baba TV, Sanyuka, all of you who were able to relay this broadcast. We thank you very much. Thank you very much, Honorable Minister. Thank you very much, Dr. Nanyonja. Thank you very much, Professor Kirenga. Thank you very much, Honorable Winnie Kiza. And thank you very much, RDC Phoebe Namalindwa. Thank you very much to the production crew that stay up late to deliver the NBS Frontline to you. From me, till next Thursday.